Afternoon, everyone, and welcome. Without more ado, let's dive in. Botched up beds. How to avoid a repeat of the NHS bed crisis this winter. Disclaimer, the small print. I basically assume you're doing all the good stuff you're supposed to be doing, and I assume you'll take whatever I say and apply it within your means. Okay? Policy-based evidence. Basically, you've been fed a load of tosh, which has constrained your thinking to believe that certain things are true when they are not true. Okay? So if you do demographic forecasting, it is not proven, never has been scientifically proven, demographic forecasting does anything of relevance in the real world. Okay? If you use demographic forecasting, you will consistently under-forecast the future. Department of Health love it because it means you need fewer beds. End of story. Okay? So your perceptions around how you can run hospitals, and it's all been skewed. Just so my own work, 200 studies, only ever cited twice in official documents, both times taken out of context. Okay, everything you can think of, NHS tariff, HRG tariff, full of serious flaws, never discussed. You can work your way through every policy stream you can think of. It's just full of flaws. And the whole policy process suppresses anything that contradicts policy and presents a facade of how the NHS should work or how the politicians would like it to work rather than reality. So we're sort of stuck in this. Okay, deaths versus demography. All the evidence points to the fact that greater than 55% of a person's entire consumption of a bed occurs in their last year of life. More specifically, in their last 22 weeks of life. Okay? This is irrespective of the age at death. So if you want to forecast demand, look where deaths are going. Okay? Hence, the trend in the absolute number of deaths drive the marginal changes in bed occupancy. Okay? So, demography, once you do the calculations, only leads to a maximum of 1.5% per annum growth, which has never occurred. Real growth, 3 times that. Okay? This will be coming out next month. Roy will be featuring it on nhsmanagers.net. What the ONS forgot to mention. Okay? Dashed black line are the actual number of deaths that have been happening in recent years. All the nice coloured lines are the ONS forecasts which have been done various years in the past, predicting into the future. Okay? No forecast ever anticipated what is happening in the last couple of years. It is completely unprecedented. We are running at the number of deaths that you would expect 20 years into the future. Yeah? You don't see headlines about, 20 years into the future, it just doesn't hit the news. Okay, so that's a bit serious. There are a couple of repeats, if you can actually look carefully. which have been buried in the overall downward trend in deaths. There was something that happened around about 2002-03 and 07-08, mitigated somewhat by the general downward trend, but not as bad as what's happened recently. Okay, so we sort of need to know what's going on, really. Key facts. These surges in deaths can be traced back to the 1950s in the UK and the 1960s in the USA, based on healthcare costs. In the USA, each of these surges triggers what's called the health underwriting, something or other form. Basically, all the health insurers go into deficit when these surges happen, because all their premiums are all worked out based on age standardisation or demography, and just all of a sudden they just get overwhelmed. So they all run into deficit simultaneously, as does the NHS. Each surge generates about $1 billion of unanticipated costs. I've documented that. Surges centred around 2003 and 2008 occurred during the Blair years of 8% growth in funding. Okay? And the 8% growth just swamped the surges eventually, and everybody got back into financial balance. Okay, every additional death generates around 10 extra medical admissions. So if you think of the previous chart, you might start thinking, oh, no wonder we've got medical admissions coming out our ears. Yeah, only medical admissions that increase. Surgical don't, trauma don't. However, staff sickness absence, the gender ratio at birth, stillbirths, certain congenital malformations, A&E attendances, the ratio of follow-up to first attendances, all jump together. Okay? That's fascinating, isn't it? That's certainly nothing to do with policy, okay? Or austerity, for that matter. A possible cause. All the evidence points to outbreaks of a novel type of infectious agent. My own research shows that mini outbreaks are occurring continuously in about 1% of small areas at any point in time. And you see in these little small areas, deaths just suddenly spike massively. This is an aggressive agent, okay? Occasionally, it can interact with influenza to give a period of augmented deaths, as seems to have occurred in 2015. Remember, 2015 was the biggest jump in deaths in the last 30 years or whatever it was, okay? Females and males behave as totally separate compartments. So you can actually have males kick off before the females, or females kick off before the males, and it's sort of like a distribution about the average. And that's basically because it's very, very heavily chance dependent about whom the agent affects, whether they're a super spreader and who's in contact with whom and so on, okay? They aggregate to give larger local events and then some really big, occasionally, some really big national events. Okay? Seen in all Western countries, probably elsewhere. Whatever the cause, levels of A&E attendances and medical admissions are not obeying any otherwise known phenomena. So, if you don't like that explanation, you're welcome to search for a better one, okay? Now, I use running 12 months totals or moving, is sometimes called a moving total or a moving average. Use it a lot. Because a moving total is wonderful for detecting a step-like jump in medical admissions or deaths or whatever. And in a moving total, okay, you're going along at the old level, you suddenly jump to the new level, so you're at the old total, you now add in 1 month of the new higher level, and that generates a ramp. So whenever you see like sawtooth-like behaviour, you know that behind the marginal changes are being driven by these step changes. And that's why everything collapses together. So social care gets overwhelmed. Nobody's expecting a massive 10, 15% step change. There's just no one's prepared for it. Acute care just gets wiped out. The ambulances get wiped out. Everybody goes down together. And you can see it's been happening regularly. Back into the past. And there's demography down there somewhere, not really bothering anybody. Okay? So, quick summary. The marginal changes are driven by death rather than demography. There is evidence for small area outbreaks of a presumed infectious agent. Emergency admissions, mainly medical, show unprecedented step-like jumps in activity. There is clear implications to anticipated bed demand and profound implications to the STPs. Okay? No one's going to balance the books until we address the cause rather than the symptoms. Now, I often email Roy and say the NHS is being hung out to dry for the consequences of a massive infectious outbreak. Okay? So, NHS bed strategy. So here are the trends from hospital episode statistics going back to 1998-99. And you can see that these are occupied beds, so heads in a bed. Occupied beds have been declining since about 2002-03 in the surgical side of things. Day case rates have increased quite dramatically, and the surgeons are getting very good at reducing length of stay. And there's very little evidence to indicate that chopping surgical length of stay does anybody any harm. Okay? So that's going nicely, and will probably continue to do so. However, occupied medical beds are showing these huge surges for no apparent reason, other than you'll find that these little small area outbreaks are all aggregating up to give these huge increases, not only in admissions, but complexity increases simultaneously. Because as far as I can discern, whatever is causing this manipulates the immune system. And so it hastens disease progression and enhances symptom severity. Welcome to give me a better explanation, but you can see how it's affecting the pressure on medical beds. I mean, this is not made up, this is real HES data. If you go back as far as you want with your available data, you will find exactly the same patterns buried in your data. Okay? Use a running 12-month total rather than annual totals, but you know, the annual totals are good enough to show you the big national outline. Now, at individual local levels, the timing will be shifted because of the whole randomness and random movement along social networks and who gets infected and so on. So you've got the broad outline, but there's the specifics that will be at your local level. So, and because of the high level of randomness, you'll have one hospital will be affected slightly, and another will be massively affected simultaneously. And you know, the hospital that's been badly affected, the Gestapo will descend upon them and slap the managers about the face and tell them they're useless. Okay? You know the story.
Can I just ask you that?
Yeah.
That graph being correct with the delayed transfers of care?
Okay. Little history, snippet of history. Every time these events occur, delayed transfers of care shoot up because social services are overwhelmed. And you've all forgotten the last time round, and the time before, and the time before. I've been around for 25 years, and I can assure you, every time it happens, social services gets overwhelmed. It just makes the situation worse, okay? But it's not a fundamental cause.
No, I was just thinking that it lengthens the amount of delayed transfers of care. It lengthens the length of stay and therefore the overall bed demand. And that graph kind of coincides with extra funding and then lack of extra funding.
When these things happen, it sucks money out of the system. And then people respond by sticking a bit more money in, and so you get the perception of cause and effect, which is distorted because nobody's acknowledging the real fundamental cause. So we're running around putting sticking plasters on symptoms rather than addressing causes. But irrespective of whether that is true or not, that's reality, however caused, yeah? And that's where your bed planning becomes really tricky, because you're not anticipating these massive surges, because nothing you've been told fits in with these massive surges. Okay? Okay, now let's go into the deleterious effects of high occupancy. I mean, there's just masses of stuff in the literature about what high occupancy does to a hospital. Queues in the emergency department, staff stress, disillusionment and use of antidepressants, hospital-acquired infections, not just the ones you have to report about, increased never events, increased falls, cancelled operations, high bed management costs. I mean, your whole bed management team, in an ideal world, you wouldn't need. Okay? They're just running around putting a plaster on the fundamental problem. Patients on trolleys and in other specialty beds, little old ladies in the trauma beds, infecting everybody on the, you know, you know the story. The full cost of this chaos has never been quantified. It's just become entrenched in the cost base. Okay. So here's a from queuing theory. Erlang, A.K. Erlang, developed queuing theory to understand telephone exchanges, and his equation predicts that if you don't have enough servers, the calls will go away. They'll be turned away, unavailable service. So here's your beds. If you've got X number of beds, the equation says that at a certain average occupancy, you will have a certain level of turnaway. Okay? And at a certain number of beds, the higher you run the occupancy, the higher becomes the turnaway. Now, turnaway is all of those things on the previous slide. The chaos just ramps up. The apparent complexity of running the hospital ramps up. The staff begin to feel as if the management haven't got a grip. because just chaos is descending upon them. It's entirely predictable. Okay? Now, look at the nice little golden blobs. That's the USA. Okay? The USA is largely a private healthcare system. They don't want turnaway because they want money. They want the money now. So they have sufficient occupancy not to have turnaway. So in an ideal world, the NHS should be operating somewhere about 80% average occupancy. I know you're never going to get there, but I'm just telling you, that's an ideal world. Now we come into seasonal effects. Now this is greatly simplified. I've just taken quarterly data for the whole of England to illustrate the concepts. So I've taken a 7-year view of quarterly bed occupancy, and I've scaled it to roughly about a 1,000-bed hospital. Okay, so here's our manager, and he's trying to run his 1,000-bed hospital. Now, over the 7-year period, he can experience anywhere between the minimum and the maximum in a quarter. So how many beds should this man have, or woman? How many beds should he have? I mean, that's national, with all the small area of variation averaged out. I mean, if it's that bad nationally, what's it like locally? Okay, this is why is it so difficult to run a hospital? Because it is. It's supposed to be difficult. Because the natural world around you conspires to do all sorts of strange things with emergency admissions. So, for example, trauma admissions follow long-term cycles which appear to be driven by the weather and climatic conditions. And you'll get periods where trauma will be really high, and then it will just dissipate away and go into the next cycle. Very long-term cycles over 25 years. Big surgery tends to be less sensitive to the external environment, but there are some medical aspects of surgery that'll bring little cycles into surgery. But it's in medicine that you get sets of complex cycles. So you get various conditions will respond to pressure, others will respond to humidity, and all sorts of stuff happening. Plus, then you get the outbreaks of this bigger agent imposed on top of that as well. So you have a set of complex cycles. So the question as to how many beds should you have is, well, you take the maximum point, but you don't leave them open all the time. You build your hospital with flexibility such that you can close little modules of beds at will so that you can flex within this huge demand envelope. That's the theory. In practice, you don't get the money to build them, do you? Okay. Length of stay. You're all being driven to reduce length of stay, which is admirable in itself. However, the demand is primarily driven by the volatility in arrivals, not by the length of stay. So it's, length of stay does have a secondary effect, but it's primarily the volatility. So there's actually little international evidence to show that length of stay actually has massive reductions in costs. You just release the bed faster for the next arriving person. You cram more into the shorter time that they're there. Obviously, there's exceptions to that general rule. Non-room costs are highest in the first day, and NHS costing and pricing is woefully, abysmally crude. It allocates costs across length of stay in ways that have no relationship to reality, and therefore in STPs generates imagined savings of enormous proportions, which do not exist. Okay? So non-room costs, day one, 282% higher than the average. Yeah? Day two, 60% higher than the average. Day three, 14%. And then you go into negative. Oh, you know, so that was there's a reference there. There's a 6% increase in readmissions for each day lower than the case mix adjusted average for that individual. And that's mainly for medical, not surgical. It doesn't apply to surgical. Okay. And in the NHS, the apparent continued reduction in average length of stay is actually an illusion created by 1.7 million same-day stay admissions, which are counted in the overnight emergency average length of stay. Yeah, I doubt very much that there's actually been huge reduction in the real overnight stay length of stay over the last decade. Okay. Yes. Yeah. No, I know. People don't. CCGs don't understand that concept, do they? They think that length of stay reduces ad infinitum. It can't. It'll go to zero in about 15 years' time. Can't do it. Okay. Real length of stay has actually increased. It's probably got worse in 2016-17. This is just showing I've recalculated HES data, and here's the real versus the apparent length of stay for various conditions. Note the high predominance of obstetric conditions in this list, which has lured managers into closing obstetric beds because length of stay efficiency is getting better. Okay? Ah, what joy. Okay, here's the change in the real overnight stay length of stay since 2001 up to 2015. Okay, you can see, and there's the bottom axis is the change in overnight admissions, and then the y-axis is the change in the length of stay. And you can see zero's roughly in the middle. So there's been quite a few diagnoses which have increased in number. Some have reduced. Quite a few have actually shown substantial increases in length of stay. And those are the ones where you've stripped out all the simple stuff, leaving the really, really, really complex stuff behind, which is happening obviously as you do more day case, and so on. So there's this huge stuff going every way simultaneously. If you put your finance cap on, all the cost-volume relationships are simultaneously changing, whereas the tariff assumes steady state. Okay? So, beds, you've got to change your thinking. Beds are an asset. Too few beds creates chaos and costs. As much as you are humanly able, you need to have enough beds for all contingencies. Wards need to be able to be opened and shut as required. It is actually possible to get a good winter where the bed demand is about summer level. It's possible. I can document numerous instances back for the last 25 years where that's happened. You need to start staffing patients, not beds. Obviously, if you haven't got enough beds, you just staff the beds, because they'll always be full. You need to, in the ideal world, you'd start to think, how do we staff patients and their acuity, not just beds? Oh, that ward has to have 4 nurses. Not necessarily. Yeah? Only if the acuity justifies it. Bed management shifts to moving staff to match need. Move delayed discharges out of the way into a delayed discharge ward. Staffing levels, and this is my key point, staffing levels are set by the financial constraints imposed by the government. So safe staffing levels are a myth, because in the NHS in England, the number of staff is fixed by government and imposed by need to recover deficits and stuff like that. So you can ditch that one. Solution: always, always, always build day surgery and assessment units with excess capacity. Okay, that's the simple rule. You always have massive, great day surgery unit. Because when you hit bad times, you just move all your surgery into day surgery. And behold, your surgeons will find innovative ways of doing day surgery on patients that were deemed not possible yesterday. Okay? There you go. And your assessment units have to be big, because same-day stay assessment unit is the growth industry that's powering apparent NHS growth. So that's where you stop them getting into the overnight bed pool. Yeah, you pull the number of 1-day and 2-day stays down, because your assessment unit is fully resourced. Yeah, and with people who have a dedicated mindset to out the door. So that's, if you're cunning, that's where you're going to put your capacity. So, key recommendations. The current surge in medical demand will abate exactly as it has done in the past. I can't tell you how long before it will come down the downside. This time has been particularly bad, but it will eventually abate back to baseline. Do not invest in new build estate to service medical overnight demand. Okay, that will abate. As I said before, alas, these beds are largely devoted to end-of-life care, mainly in the last 22 weeks of life. Okay, we are keeping the soon-to-die alive, basically, in very large numbers. This fundamental demand has to be dealt with via non-acute solutions. And I suspect a large part of that will be elderly care physicians sort of moving flexibly between the hospital and the community to support GPs and GP equivalents out in the community. New build has to be in day surgery capacity. In fact, if you look at the trends, day surgery beds are starting to fall behind the growth in demand. Yep. Because you've got this mindset, you're obsessed with building everything too small. And then demand catches up with you, and you've just spent 25 million and it's full now. You should have spent 30 million. and done a decent job in the first place. Okay? Okay. Rapid medical assessment. Excess assessment beds are needed to accommodate the surges in demand, which will happen short term and long term, and they maintain the flow out of A&E. It's not rocket science. Thank you.
Rodney, thank you. Okay, has anyone got any questions? Anything they want to raise? Yes, far away. Just tell us who you are, and just wait for the microphone so we can get you on.
Hi, I'm Margaret Dial. I'm a Director of Clinical Operations at Medway. I'm just interested if you've seen, so in this 25 years of studies, have you seen somewhere where they've actually built to the growth rather than to the actual, and have seen that working? So from those recommendations, have you seen that in practice anywhere?
No.
And why do you think that is?
Because there's this mindset, we need fewer beds. We need fewer beds. Don't think any other thought other than we need fewer beds.
Is that a financial drive, do you think?
It's part of this policy misinformation that only thoughts consistent with policy are ever entertained.
We went through a period, didn't we, where average bed stays halved, I think, in 5 years. And they halved a lot because of better technologies, medical technologies, and the influence of superior pharmaceutical solutions, and the bed stays dropped right across the piece. I think they went from an average of 10 days to 5 or something, and then for the elderly it went from 14 days to 7 or something. And that seemed to me to be kind of comfortable because there was a reason for it. What I think health service managers have done now is they've assumed that trend can continue, but without any reason for it to continue other than we've got a reduction in bed stays. And because Rodney's right about same-day surgery, I think measured across Europe, we've got one of the lowest levels of same-day surgery in Europe, which I don't know what the explanation for that is, and I don't know what the drivers are for this. But I think the worrying thing is now, the real contemporary thing is that we've got SDPs who are planning the future of healthcare for 5, 7, 10 years, making assumptions on the reduction of bed days, moving people into the community, which I think most of us would regard, with the greatest of respect to our colleagues who work in primary care, as underprepared for being able to look after people in the community. And that isn't to say that it can't be done, but the reduction in district nurses training places, the frailty of primary care, they can't, in a lot of places, they can't even get their phones answered because they get swamped with demand. So the whole trend, the policy trend, strikes me as being a great risk.
We're in a mindset, build it too small. Nobody's will step out of line and throw in excess capacity.
I think the other thing, of course, is the absence of capital now. There's a lot of talk about releasing unused capital in the hospital estate. Well, it's disaggregated. It's hard to carve a piece off and sell it if it's mixed up with each other. It seems to me that what we should be doing is leasing our unused bits of the estate to care home company providers, step-down care, and so on and so forth. So we don't have to have the capital costs of the capacity issues. And that, and I think you make a very good point as well, is the way the costs are calculated. Beds are only expensive because we use a formula to calculate that to make them seem expensive. But actually, if Premier Inn can give us a bed for 57 quid a night, why is it costing 300 or 400 quid in a hospital? It's the way the calculations are done, I think.
The apportionment of costs based on length of stay.
Yeah. A question here at the front. Oh, sorry, this gentleman first, and then we'll work our way to the front. Yes, sir, just tell us who you are.
Hi, Steve Blake. I'm an independent data scientist. So the question I've got, so what we've just said is interesting and may help us plan better in the future, but nothing that you would recommend would actually happen very quickly. And I want to try to challenge that and ask whether or not you think there are things people could do right now that would make a big difference to how beds are occupied in hospitals. So I come from a kind of, let's look at the operational detail of how hospitals actually manage flow-through beds. And we look at what time emergency arrivals turn up, what the demand looks like. We look at what time discharges happen. We look at how many patients actually need to be in a bed. Clinical audits, do they still need to be in an acute bed? And what you find by looking at that sort of bottom-up level is, first of all, half the patients currently in a bed right now don't need to be in an acute bed. The reasons why they're still there are because we haven't got the operational processes of sorting out discharge, coordinating the next step, actually done well. And we find that typical discharges in hospitals are late in the afternoon. That's the peak time. Typical demand for the beds is actually in the morning, because that's when emergency arrivals tend to turn up. And a total failure to get to grip with that basic operational process means we waste maybe 20% of all the beds like that every day. So I'm just interested whether you've analysed things like that in terms of how do we actually get the operational processes sorted out.
There are people like yourself that specialise in doing just that. Yeah?
There is some very interesting data from a guy from, I think it's from Northern Ireland actually, who's done an analysis of people who are admitted later in the day stay longer.
Yes, actually it'd be Seamus McGurr, I presume.
That's it, yeah. That's very interesting work.
Yeah. But I come at it from the pragmatic side of, this is where you are now, therefore this is what you're going to need unless you can change your system fast. Yeah.
I think there's another issue as well. It starts outside hospital. I was with a big acute hospital just recently, and they were worried about getting people out, and they couldn't because of the relationships they had with social care. Now, Jeremy Hunt is saying that we will get back on track by 2018. His gamble is that the $2 billion that's gone into social services will enable social care to find the capacity to get people home quicker and get the flow going through. I mean, that's a huge gamble because there's no guarantee that capacity can be found at short notice, and the industry itself has been damaged. 92 contracts, I think, with domiciliary care handed back. One care home a week is closing. The extent to which we can repair that quickly. The other way of looking at it, I think, is to analyse where people come from to come in. And the analysis that we did was on the postcodes. It's very simple to do. We just did a postcode analysis of where the admissions were coming from. And we found that they were coming from, I think it was 4 postcodes, 2 general practices, and 4 care homes. Now, once you know that, that's pretty easy to solve, because you can use community matrons, you can use better training, there's all kinds of things you can do. So it's looking at where it comes from, isn't it? As important as where it's going.
No, I agree. I can give you a map.
Yeah.
In Excel. You don't have to buy any special software. Uses free stuff available from the Office of National Statistics. I can show you the location of every nursing home. I can show you the social group that lives in that little area, and you can superimpose the number of deaths that happen. So deaths equals demand. It's a doddle to do, but nobody does it.
There's a very nice piece of software called Pi, spelled P-I, which is available for care homes, and it tells you where the frequent flyers come from the care home. Sorry, you had a...
I just wanted to... There's quite a narrow point, because one of the things I find when talking to hospitals is they love to blame social care for the fact that they can't get patients discharged. Yeah. But we've got quite a lot of data on that, and all the data we've got says social care causes a big problem and it's getting worse, but hospitals cause twice as many problems in delaying people getting discharged.
I think it's easy to draw that conclusion from the data, but I think there's another way of looking at it. You are right that 37% of delayed transfers of care, I think I'm right in saying, are attributable to social services, and 52% is down to the hospitals themselves. However, you may regard the delay in the hospital processes as not being a delayed transfer of care. It's being a delay in getting ready for the transfer of care. So there are internal referrals, there's pharmacy, there's outcomes of imaging and so on and so forth. So you could say actually, although there are delays, we could get them to the exit door quicker by speeding those delays up. Actually, they're not responsible for the delayed transfer of care. The actual delay starts when everybody says, Mrs. Bloggs is ready to go. And social services say, we'd love to help you, but we haven't got enough care packages. So it's another way of looking at the data. Hang on, could you just wait? Would you mind waiting for the microphone?
One of the other issues is the longer you delay a patient, the more likely they are to get reinfected, and then they come off being a delayed transfer and effectively like a readmission.
Yes.
But you don't readmit them.
No, you're quite right. I mean, ESIS has done some work about, what is it, every extra day, Terry, is it every extra week day they're in hospital is like a week of loss of acuity or something. I mean, it's a very dramatic
I'd just like to respond to the gentleman's point over there. I mean, he's perfectly correct. I mean, we've done all that stuff. And it made a huge difference.
You're from Southampton?
I'm from Southampton General.
Yes.
We did all of this stuff around flow and basically looking at our discharge and really driving that discharge process through. And we cut down the number of black alerts we had from, I think, 56 days last year to 5, I think, this year. So we did really good. But it doesn't take the problems away. The problems are still there. We are, 95% occupancy, just barely surviving on them, where we are. But we've already done all that stuff. Yeah.
Interesting. I wonder if you'd mind if I moved on. We'll take a final question before we go to the next speaker. Jill de Benet, who's the Chief Executive of the Institute of Health Managers.
Thank you, Roy. Thank you, Rodney. Just really 2 reflections. I think I agree with the gentleman about the window of opportunity to discharge and what you were saying, Roy, just now. But the size of the infrastructure that you were talking about, whether the hospitals have been built big enough. I think part of our problem, and I was at South Bristol Community Hospital, which is an amazingly spacious 60-bedded community unit, is that we have an ingrained, if it's big and it doesn't look like it's busy, we think it's wasteful and we close it. Is that your experience as well?
If I can say, big and relatively quiet creates a sense of calm and well-being. Everybody thinks the show is under control because there are some empty beds
I don't
around.
want you to go all yin and yang on me. I like it better when you're a number cruncher. But it's better. But the real risk, I think, is the view the STPs are taking over moving people into an unprepared community. That was fascinating. Can we say thank you to Rodney Jones?